So, hello everybody, welcome to another session. We just want to make a quick reminder and make sure that any voting delegates in the room, make sure you have voted. Thank you.
Good morning. My name is Shannon Turner and I'm a member of the Education Committee. I'm excited to welcome you to Competency-Based Education in Physical Therapy, Potential Impact on Public Protection. Competency-based education is being discussed and implemented as a core strategy for education and assessment of learnings in many health professions. This session will provide an overview of the progress to date in physical therapy education and will discuss the implications of CBE implementation in physical therapy and its potential impact on regulation and public protection. The speakers for this session are Stephen Ambler, Jean Fitzpatrick, and Gail Jensen. Steve Ambler is a professor and division director of education at Washington University in St. Louis. Jean Fitzpatrick is currently the co-director of a competency-based educational program for licensed physical therapists working with patients with spinal muscular atrophy. And Gail Jensen is vice provost for learning and assessment and professor of physical therapy at Creighton University. You can find their bios in the event app. They have valuable information to share, and we also encourage your participation throughout the session. If you wish to ask a question during the Q&A portion, the members of the Education Committee will provide you with a microphone. Please abide by the ground rules in the program notebook so more attendees have a chance to ask questions. At the end of the session, please scan the QR code to complete your evaluation because we really value your feedback. Now I'm going to turn the presentation over to our speakers.
Thank you. Good morning. Oh, I don't need that yet, but I'll use this for now. So yes, my name is Jean Fitzpatrick. I actually am the director of the program of physical therapy at Columbia University. That other piece was a little thing. I'm really very fortunate to be speaking with Gail and Stephen today, and we're really excited to share some updates. And I'm hoping many of you have heard some of it, but I think it'll make for interesting conversation. So as mentioned a little bit, our objectives today are just to kind of talk about, why CBE? Why are we even thinking about this? What is the impetus for this change or the discussion of this change? Talk about some common language so that we have this shared language that we're all using so that we're all, comparing apples to apples. Talk about the national work that's been going on and our progress to date. And then discuss some potential implications of CBE on regulation and public protection. So I'm going to hand the microphone over to Gail, and then she'll be back.
Thanks, Jean. I just have a few slides here to set the stage, kind of at a broader view. So do we need a change? Why are all the health professions moving this way? Well, we need to think about a learner continuum, and that's continued competence from admission to a program across a career. And that means evolving standards of practice that are meaningful, necessary, and not just regulatory. I know we're talking to a room of regulators, but meaningful assessment. So thinking about how competency-based education can move us to competency-based practice, and you'll hear more about that because the assessment of CBE is done in the workplace. It is workplace assessment. And the question is, do we need to embrace the collective ability to self-regulate and adapt to the societal needs? And you'll see a couple more slides here. You heard Rich this morning, and he was really pointing out, here's a visual he could have used, the complexity, the need to tolerate ambiguity. When you look at, we've got community needs, we have societal needs. We don't do a good job with health. We're about the 11th country in the world, I think, in terms of our health outcomes. And so you've got the patient in the middle, but you've got both the systems of healthcare, but you've got educational outcomes, you've got the higher ed system, you've got the healthcare team. You can see the complexity here. And that, in turn, is part of what we're trying to navigate. The other thing is to take a balcony view, to take a systems view of what's going on. We can look at the individual learner, but that learner is going to work in an organization, and ultimately our obligation as physical therapists is to meet societal needs and the quintuple aim. And are we doing a very good job of meeting that aim? I would say the answer to that is no. And that's probably no across the health profession. So there are pressures on us at every level. And when we think about what are the drivers in medical education, a couple of years ago we had Dr. Robert Englander give a keynote at the Educational Leadership Conference, and he was at the AAMC when they moved forward with competency-based education. This is what he shared were drivers in medicine, and I think you could look at this. Are these also for us? You heard this morning about knowledge explosion, siloed curriculums, we have over-specialization, we have certainly student debt. Lengthening education is not sustainable, and our inability to meet those societal needs. So all of these also apply to us, and that's where I think CBE has something to offer us. And I'm going to turn it back over to Jean.
I'm not very good at the podium, so if you don't mind, I'm coming down. So I want to bring it now to the PT level. So we talked a lot about, well, Gail mentioned about medicine and the impetus for change in medicine, but we don't just want to do what medicine does for just to say we are doing it. But why in PT? So what's the impetus of change? Why are we even thinking about this? And really it's unwarranted variation. We can think about the number of PT schools. There's probably over 300 now. Each school they define their own outcomes, what is considered entry level. And you know, CAPT requires some things for us to report in terms of our licensure pass rates, our graduation rates, and our employment rates. And what we define as entry level, each one of those 279 plus that was just reported in last year's AAR schools make that decision. So you can probably think about having all of those definitions of what is entry level coming out of each of those schools, that when we have our graduates entering clinical practice for the first time, there's varying amounts of skills. So given that, we're trying to reduce that unwarranted variation when they enter, and then certainly within practice. Does it not advance from down here? Oh, there it does. So again, we know from the literature that reducing that unwarranted variation, and I want to emphasize unwarranted variation. I mean, PT schools, there's lots of good variation that makes them different from other schools that attracts students to attend there, but here we're talking about unwarranted variation. So we know that reducing that will definitely decrease. We want to have high quality care, the best high quality care for all of our patients. And if there's such variability coming out, we know that every patient is not going to get that. And we constantly are kind of using this phrase is, would we have every single one of our graduates entering clinical practice treat a family member of ours? And I don't think we would all say yes to that. And that's something that we want to reduce. We want to reduce the number of times where we're like, not so sure. So we want to try, our overall goal is to reduce that unwarranted variation and improve outcomes. So the traditional model, I'm trying to use this, so the traditional model that we're all used to is we have a curriculum that we're told, like CAPT has content, the 7 Ds for all of that know, that we have to make sure that we cover. So we have this content, and then we make these objectives, and then we find a way to assess them, and we're like, okay, you're good. But with a competency-based model, you start with the end in mind. You think about the physical therapy health needs of society. What does society need from us? That's where we start. And then from there, we then say, okay, if this is what they need from us, then what does the person look like? What do they need to have within them? And what do they need to be able to do as that PT to be able to meet those needs? From there, after you've described what the person must have within them and must be able to do, we then establish a curriculum and figure out a way to assess it. So it's a backward design. So there's a couple of terms that I just want to make sure that we're all on the same page, because you'll hear these words, competencies, you might have heard the word EPA, fancy words, like what do they mean? A competency is a characteristic of a person. It's a quality within a person. And if you had a whole, like pretend we just made a list of a phenomenal PT, all the characteristics of them. If we group those competencies under similar themes and we put them in buckets, those buckets would be a domain of competence. So you could have a communications domain of competence, and all the competencies that were in there would be related to something about communication. And you could say the same thing for maybe professionalism and knowledge and all that kind of stuff. But if you looked at all of those this one, I don't remember which button. If you grouped all of those domains together and looked at them as a whole, they would capture the essence of the physical therapy profession. Then there's a thing called an EPA, an entrustable professional activity. It's a fancy word because if you think about it, if you describe that crazy, phenomenal PT, there'd probably be a lot of competencies which would be really hard to assess all the time, making it hard on clinical instructors. And it's also very context dependent. So like, for instance, my kids, when they got their driver's license, they were able to drive. But I live in New York, and driving by my house versus driving in Manhattan, two different things, so it's context dependent. So EPAs were described by Ola Tenkate back in 2005, I believe, and it was really meant to make assessing this a little bit more feasible. So an EPA, an entrustable professional activity, is a fancy word for our job description. It's the essential activities of a phenomenal physical therapist. It's what you went to PT school for. It's not the added stuff that we all do. It's what we went to PT school for, and it would almost be listed in our job description. They're the day-to-day essentials. And that really, the day-to-day description really describes our clinical care, where regardless of the setting, but it describes our clinical care. So two separate concepts: competency, a person, characteristic of a person, and EPA is an activity. It's a thing you can see somebody doing. But while these concepts are different, they are interrelated in the sense of, if you have an activity, a task to be done, you need a person with a set of skills to be able to do it. So they're intertwined. And this is just describing, so here, if we had an activity, let's say perform a history physical exam, you could probably think of a bunch of competencies that you would need the person to have to be able to do that activity, and they would probably fall in a couple of different buckets, like maybe patient care, medical knowledge, or a knowledge of practice, and professionalism, communication. You can add a few more things, and each of those buckets would have a couple of those competencies that I talked about. So you can see how they're interrelated. So the vision of education and training is that, if you think about it, for our students that we're currently teaching in entry-level practice, our hope for this is that we are defining what are those entrance into practice essential activities, and what are those essential characteristics, of a person. So what are the competencies and what are the activities for entrance into practice, because we were kind of guided to start here, because then you can move forward along the continuum and certainly move back. But here we're talking about the competence from when they first start entry level, but we all know we don't stop learning and practicing, right? We go into clinical practice for a reason, because we want to continue to practice. But the goal there is that we move into what we call competency-based practice, where we keep practicing until we become experts. So our students certainly aren't experts when they graduate, but they are competent at a certain level that we've defined. And that's what we're trying to come to consensus with, is what is that set of competencies and that set of activities that our students should have from when they first graduate, and then what should it be down here and down here, and we can keep talking about that continuum. But our ultimate goal is that we have this mastery learning and practice for all of us, because we know that our students are never going to be assessed in everything that they could possibly see in their careers, right? So we have to kind of throw them some 8 balls and throw them some different things to say, what would you do if, or what would this happen? And we make judgments in that moment to say, you know what, I think they're good to go out, but as to enter the clinical world, but then from there they have to keep practicing throughout their lifetime and become experts, and when they stop learning, that's when it's time to retire. We just want to kind of give them that. But it really, competency-based education, the thought is to really inspire, and we really, the best place to really try to start with it is when they're in school, is to instill that lifelong learning. We're teaching you this, and this is going to get you to here, and this is what we have to ensure, but you need to keep working on it, keep practicing in those different contexts so that you develop expertise and you become that master adaptive learner. So that's my very quick version of competency-based education. But now I just want to tell you what, we've been working since 2018. There was a group that met at APTA. We had a bunch of, probably at least 25 different stakeholders from all over, representing students, faculty, different professions, where we had a meeting to say, do we want to go down this path? And at the end, it was an outcomes meeting. At the end of that meeting, it was decided that we wanted to define those essential competencies for entrance into practice and to come up with the EPAs. Since 2018, there's been a lot of work, and the reason why we have this slide up here is that we want to show you that this wasn't 3 people in a room that just kind of came up with something and then put it out there. It's been really very elaborate. Some people almost say it's too elaborate, but we really want to make sure we're doing it right. So you can see here that, like, it's hard to see because it's really, there was a lot of steps. But we started back the domains of competence group. They were charged with coming up with those buckets, as well as the competencies underneath for entrance into practice. And while they were charged, to do entrance into practice, those domains, the bucket titles that capture the essence of the PT profession, that goes across the continuum. So those titles, those buckets should be, the same for entrance into practice as it should be 10 years out, as it should be 20 years out. It's the competencies within them that will change depending on the benchmark, the point in the continuum that you're looking at. So looked at the literature to see what are the domains that are out there, what are the competencies that are out there. We had lots of discussions. We developed a framework, and we also instituted a reactor panel. So the reactor panel was created purposefully of over 200 people, and it had stakeholders from, again, students, faculty, clinicians, mostly clinicians, more than 50% are clinicians from different settings. Also people from outside of PT education, CBEPT, FSBPT, everybody was represented in this reactor panel, and their task was to give feedback on the work of this group and the EPA group. So each time we gave them stuff, they gave feedback on clarity and, does it seem right, does it seem essential, and I'll go through that. But so the reactor panel gave us feedback on the titles and the descriptions of the domains of competence. Then we came up with a glossary and preamble. Then we got feedback, reiterated, went back and got feedback again. And then we moved on to the actual competencies. We went through the essential competencies, had the reactor panel give feedback. So now, just so you know, we're at the point, so we had 3 rounds of that, and then after the reactor panel, we opened it up for public comment. So it wasn't just the 200 people in the reactor panel that gave feedback. We opened it up, and for a few months, the link was shared with as many people as we could, different sections, different academies, different groups shared it to give comment on the domain titles, the descriptions, and the competencies. So right now, there are 53 essential characteristics or competencies of individuals that have been defined for entrance into practice that go into one of 8 buckets. So these are our domains of competence for the physical therapy profession. Knowledge of practice, and the number next to it tells you how many competencies were underneath there. Communication, patient or client care services, professionalism, education and learning, reflective practice and improvement, practice management, and systems-based practice in healthcare. This it has been submitted, and hopefully, the methodology of this has been submitted to PTJ, so hopefully you'll be seeing that out in print soon. And then, so this is the domains and the domains of competence. We also had another group that looked at entrustable professional activities, fancy word that we're not really used to, so we felt that our drafting panel needed to get some education. So we had a 2-day summit of training for the drafting panel, which was roughly about 15 people. And again, mostly clinicians, which we really wanted to emphasize because they're on they're on the ground. So the initial draft started with 17 essential activities. We went to the reactor panel for feedback, and then we had the drafting panel kind of describe it, because it's not just a title. We want to describe what it is. What is the actual activity? And then we had, after it was described and the group came back together, we sent it to the reactor panel to say, does this title sound clear? Does this description, do you understand what that description is? And then they gave us feedback to change. They felt that 2 needed to be broken up. So So now we have 19. There are 19 essential EPAs that have come to consensus on being essential for entrance into practice, regardless of the practice setting that the person starts in. What we're working on right now, or I should say I skipped a step. So we have 19, and what we're working, what we did is we tried to merge the two concepts. So we have those competencies, characteristics of a person, and now we have 19 activities. So what we then did is we merged these two, meaning for each of those 19 activities, what are the essential 5 to 7 critical competencies, critical characteristics of a person that are needed to perform that activity safely and efficiently? So that's what this means by we mapped 5 to 7 critical competencies. Because in essence, when you evaluate, when you assess that activity, you're assessing those 5 to 7 critical competencies. Then we went to the reactor panel, took the feedback, refined it again. Right now what we're working on is just giving what we call clinical vignettes, giving a description for that one activity, each one at a time, to say, this is what that person would look like if we would say they were entrusted to do it by themselves. This is what they would look like if they still need some supervision. To give, so that we create a mental model for everyone that's looking at it to kind of level the playing field. So I know these are the 19 essential activities. You will definitely be seeing them, and anyone who was in the session that was right in before here, I wanted to raise my hand to say, we have one that says, obtain informed consent from a patient or client. So all that stuff that was being discussed was going to be really important for here. So you can see it here, perform an initial examination. I don't need to read them all because I think, well, maybe you can't see them. So it's perform an initial exam, establish a diagnosis within one's personal, professional, and jurisdictional scope of practice, develop a management plan or plan of care, implement that management plan or plan of care, perform PT procedures, interventions, establish a home self-management program, document a patient or client encounter, refer a patient or client to additional healthcare professionals, educate others, supervise others, assess and determine outcomes of the plan of care, conclude an episode of care, identify system failures, and formulate recommendations for preventative health care, bill for a patient, triage care to prioritize resources to patients, complete a patient or client handoff to transition care, and recognize and respond to an urgent or emergent change in status. So these 19 activities have been deemed essential for entrance into practice, regardless of the setting that the person starts in. So theoretically, we're kind of defining what entry level is here by saying what that physical therapist can do when they graduate. And if a program says that they're competency-based and they adopt these, they're saying that they will not let their student graduate unless that they've been deemed safe and efficient in these activities that they don't need, that we trust that they would be able to do this without the need for supervision. So these activities are assessed in the workplace. We might, on the academic side in the lab classroom, say that they passed their practical, but all that's saying is that we believe they're ready to go to the clinic. Until they're in the clinic with patients with that element of risk, that's where we really need to make the judgments. Because in the classroom, of course, I'm like, the student's not, I'm going to watch them, I'm not going to let them harm anyone else. Their fellow classmate who is relatively, I hope, healthy. But now we go into a healthcare environment, and as a clinical instructor, do you feel safe with saying, go ahead, go in there and do that? That's where you're making that judgment. So when we assess and teach using EPAs, it's all about saying how much supervision does that person need to perform that activity safely and effectively. As clinicians, we do it all the time, right? We'll say, you go in there and do that. You feel good about them doing a history by themselves, maybe. Or maybe you're like, no. And how do we assess it? It's called a supervision scale. You remember when you write in your notes, patient transferred supine to sit with contact guard min assist? Those are kind of levels of assistance. Here, what we do is we talk about how much supervision do you think they needed in the moment? And if you had your crystal ball for the future, how much supervision do you think they need in the future? And the scale itself is just a scale that gives almost like increased autonomy. Pretty much the beginning is you're a fly on the wall. You're not doing anything. Then it's you're co-treating, it's direct supervision, indirect supervision, and then you don't need any supervision at all. So it's increased autonomy as they get stronger. So I don't want you to think that competency-based education is just all about those two things, competencies and EPAs. This is a whole gamut of assessment. If we think about habits of the head, heart, and hands, it's kind of like another way of saying it's the be, do, know. You know, we know that there's a lot of knowledge, skills, and attitudes that our students and as practicing therapists we need to know. We also have a lot of things that we want our students to be. There's easy ways we can write competencies, you know, and there's also parts of them we want them to be empathetic, right? And we want them, this EPA, these are the do's. So those 19 things fit into that area. So it's not just the EPAs, it's a whole gamut, and this is a whole process. You know, it's a whole picture of this individual. So a student, it's definitely getting more of a customized education in the sense of, you know, some activities they might need to have more help and more time with. Sometimes they might need less time with, and they can focus on other areas where they need a little more help. But inevitably, what we're hoping for is this adaptive, lifelong learner that we feel strongly and we feel confident that they will be able to go out and treat patients effectively and safely. I'm going to hand the baton over. I'm going to shut off my mic, unless you want the mic.
I think, yeah,
I'm off.
This will work fine. Yeah, thanks. Thank you. Good morning, everyone. I'm Steve Ambler, and my role today is now to provide maybe a couple of examples of how shifting to a competency-based framework, and I'm also going to mention entrustment, might impact public protection or regulation or other things I think that a lot of people who are here at this conference are interested in. So I think there's actually many ways that it could impact things or not. In other words, I think that, yes, there's the framework, but it's really what we do with it, the decisions that we make as a collective group across our different professional organizations. That's what will really sort of decide what it means to us. And I'm going to provide a couple of examples and then stop in the hopes that we have plenty of time for you all to ask questions and have a bit of a dialogue with the rest of our time. So this will be a little bit quick, but you could bring it back up if these examples are interesting, or you could bring up different ones. I think one of the most interesting things to me about a competency framework across a professional continuum, and I have this question up here: how might our responsibility shift across the continuum? Responsibility of the practitioner, and also responsibility of everyone involved in deeming that they're competent along the way or entrusted to perform certain tasks. I think a really important thing about a competency-based model is transparency. So transparency to all of the stakeholders involved, probably most importantly the public or the patient. You know, so what have I been entrusted to do? What am I competent in? Maybe might mean another level of transparency versus, yes, I had that content in school. And then maybe it was sampled enough on different traditional assessments, and then we decided that I'm competent. What you can do with competencies, and I think even more so with EPAs, is have a much more transparent documentation of what I'm entrusted to do across my career as a physical therapist. And so I focused for this example on showing you the continuum, and I'm really interested in personal scope of practice. Because I think, you know, this notion that your personal scope might become deeper and deeper and more narrow as you practice across your career, if you specialize in a particular area of practice, is really important, but it's one of the least well documented. In other words, it's up to us as the practitioner, really. And so how will we, with our patients and health systems, use something like an entrustment framework to show that I am entrusted to do this work task, 15, 20 years out into practice. Not in a box-checky, punitive way, but in a way driven by learning and our interest as a professional and what we're passionate about doing. That's going to be the real key to make sure that if we do something like this, it's really driven about our passion for constantly getting, but Jean mentioned Master Adaptive Learner Framework, and that's about we're constantly trying to get better for the next patient that's going to walk in front of us. Not that we're trying to check all of our boxes for, renewing things. So that's a tough thing. And so then I put this other question up here: can a PT really be entrusted to do it all? Can I? My background's in orthopedics, my board certification's in orthopedics, and would I really be, what was the question? You say, would you allow me to treat a family member? Would I really be entrusted by Jean if it was maybe her young child, given my background and how I've maybe not. And how would I go about demonstrating that? And then the other example that I think has so much potential is that if we develop this over time, sort of this shared language of competence across professions, will that really help us to practice at the top of our training or at the top of our licensure? And I have a little bit of an example here. This is a hypothetical. So here's another question. Will clear documentation of competence and entrustment change things like some of our traditional scope arguments? Will it improve access to care or maybe reduce errors or risk for errors? And then also, we should probably acknowledge some of the tension here. Will it threaten some of the professional distinctions that we've had over time? And here's what I'm trying to mean by that. So here's just a made-up EPA, not the broad EPAs that Jean's describing for entrance into practice. This would be maybe a more specific one in a particular health system. So manage a patient with acute low back pain. And then I put some domains that might be related to that. So if I'm going to be trusted to manage this patient with acute low back pain, there's probably some skills under patient and client care, some examination, some knowledge I need, and some communication and professionalism competencies that would all be part of that entrustment decision. But maybe also I'm in a health system where there are physicians, physician assistants, others involved who are all speaking the same language of managing a patient with acute low back pain. But the entrance into a patient could enter into the system through me as a physical therapist, through a primary care physician, through, hopefully not, but through the emergency room physician as well. And if we all are using that same language, then maybe the choice of provider becomes more about who's likely to get the best outcome, who's likely to make sure the patient has the best access versus, well, just that physical therapy does that. Or this goes to physiatry. Some of those traditional sort of professional barriers. I think personally that one of the greatest possibilities with adopting a framework like this is that it could eventually sort of reduce some of those historical barriers. Okay, and so those are just a couple of examples to maybe get us thinking, and I'm going to stop there because we've got about 15 minutes, I think, for discussion and questions from the audience. So I'll sit down here and then maybe we can all do it together.
Okay, I can go first. Thank you. Thank you for the presentation. That was very eye-opening and interesting, and I have more questions than I have answers. So I apologize if I misrepresent anything that you said. I'm fairly comfortable with the concept of domains of competency from a residency and fellowship education perspective because they have their own that they use to assess residents, entry, and then throughout. So I get that concept, but it seems like you're looking at it from a clinical education piece in entry-level DPT, and then once they get out into practice, and I guess my question is, how is that being used alongside the CPI, being used alongside the seat? Because we already have some tools, for lack of a better word, that we use to look at whether or not our students are competent to graduate and enter practice. We don't really have anything once they graduate, so I can see it being used post-education, but if we're looking at it in DPT education, once they get to the clinic, because we're looking at their practice with patients, how are we either competing with or working alongside the CPI or the SEAT or other clinical assessment tools?
Great question. So the thought is, so if you look at the literature related to the CPI, so the CPI is kind of it's kind of like a milestone type of thing. It's very, looking at the developmental progression of a particular item on that CPI. The literature will tell you that when people evaluate students or learners on that CPI, the ratings that differentiate the performance of the learner are quite low, and the reliability is very low. No matter what, all of these things are subjective. We know that. So I'm not going to say for a moment that this is like the golden ticket. But if you look at entrustment supervision scales, the percentage of the ratings that actually differentiate learner performance and the reliability actually doubles. Still not great, just want to let you know. So the thought is, we have a long way to go here. We're so in the infancy. We need to pilot and have data and all that kind of stuff. But let's just say we did all this stuff and this is what we're going to do. The entrustment supervision scale would replace the CPI. It wouldn't be in conjunction with. So these 19 activities, but remember the CPI is also like midterm and final, that the student does it and the CI or CI team does it. The thought here would be that we need a lot of data on our learners, so the more data points that we have, the better across locations, across people, and the more people that evaluate, even non-PTs that evaluate, like other members of the healthcare team, patients, family members. This is all data that would go into the university, wherever the student is, and there'd be a clinical competence committee that would look at all of that data, because you're looking for consistency. You're looking for, are there any red flags that are coming out? If you have a person who's humble, that reaches out when they need help, those are all things that are going to influence your decision to say, after that clinical competence committee looks at all that, they're going to say, okay, for number one, which was obtain informed consent from a patient or client. If they had all of this data in multiple settings that they were assessed, they're going to say, okay, from here on out, they can do that without the need for supervision. They'll get, believe it or not, it's called a STAR, if you want to use that, Statement of Achieved Responsibility, and it could go on your portfolio. And if this becomes shared language, people can see they've been entrusted to do that without the need for supervision. So it's got a long way to go, but it would, in essence, we can't burden our clinical instructors by doing more assessments with using CPI and entrustment supervision scale. And I will tell you that clinicians, this is more intuitive for clinicians, because we document that way for our patients. Why not document similarly for our learners?
Yeah, another quick comment is it has value on the curricular side. So when you look at the 19 EPAs, you begin to calibrate the curriculum, and you can make decisions about what you need to know, what's nice to know. It's not the entire curriculum, but it would really help us sort out, because we already have curriculums on overload. Yeah.
Thank you for your presentation. My question is about how does this apply to PTA education?
I'll make a quick comment, since I just did a lecture yesterday on ethics at Clarkson College to the PTAs, that I think once this framework, it will be extremely helpful to look at PTAs and where that might fit. I can also tell you I'm on the, as is Nancy back there, Nancy Kirsch, we're on the task force that's looking at a revision of the Code of Ethics. This can be public, I think. We're looking to integrate the PTA standards into the Code of Ethics. So I think there's a lot of movement here that will be very helpful. Nancy, do you want to say anything? No.
So I just want to, right now we've been working for how many years on PT entrance into practice? We have forward and back, but there needs to be stuff done in parallel for PTA, same thing, entrance into practice, forward and back.
Yeah. Good question.
Thank you. Thank you all for your presentation. So I'm thinking, we're talking about PTs graduating and entering into practice, but I'm thinking about admitting them into school in general. So my epidemiological brain starts to think about all of the variables that should be considered when thinking about whether this will be successful. So you mentioned 2018 is when this started really coming to fruition, but the post-COVID student, maturity levels, earlier points of entry into education. So coming in with dual enrollment credits and students starting the program at 19, the push to decrease the length of programs as well. So how have these things been considered? Would there be a need for changes to technical standards, to admissions criteria, to think about the students that would be most successful, going through this type of education?
Great question. We've been asked many times, so does this mean students will finish faster, finish longer? As we know, right now we have all of the prerequisites that students are supposed to have when they come in. And everybody, those are courses, but there's also a variety of life skills that people bring in. So what I I always steal this from Carrie Chen, one of our consultants. She showed us that piece of a cookie sheet that has all these different cookies on it. So it kind of represents students when they come in, and you put them into, an oven when you set it to 250. We all know that we're going to put that in, and there's some portions of the oven that cook a little faster, and there's some portions that need a little more time. So what you come in with, meaning your standards or prerequisites, are going to influence some areas and where you might get through certain things faster. Certain things you might take a little bit longer. That's what we kind of talk about. This is customized education. So does that mean that PT school can be shorter? Maybe. That's up to the school. But we all know now that there are students that get through things quick. Do we graduate them earlier? I don't think anyone does. But they might give them other things to do. These are the core EPAs. One of the things we've been working at our institution are elective EPAs. So this way they get through what they need to, and we give them other things that they can work on that will make them be more marketable. So, but there could be, this is, again, early in the process, but if we have individuals that get through things faster because of life, you can imagine if a PTA went back to school and got to get their DPT degree, I'm going to think that they're going to go through things relatively much quicker because they have a broader foundation. So they might be able to get through certain things faster, but those kind of details, the institutions would definitely, have to kind of iron out. But what we're trying to say as a profession for now is for us to come to consensus on this is what they need to look like, meaning competencies, and this is what they need to be able to do. And we do that at various points along the continuum so that the public can account that their skill set at a minimum, they should be able to safely and effectively do this. And there certainly can be a little bit of variety in terms of what schools decide in terms of do they make them graduate at that point, which could save some money, student debt, or schools might be we can't let them go, we need that money, so maybe we'll give them electives to do so that makes them more marketable.
And maybe it will help us take a closer look. We don't need 80% of the class going on to sports medicine. So I think that we do some of these electives as a market advantage. But if we are really meeting these EPAs, are we doing the job that needs to be done? The other piece here that's really critical is the learning piece. This framework is grounded in how you self-determination theory. So how do you help a learner learn how to learn? And that means they take accountability and responsibility for their learning. That is baked into the adaptive learner. And so that's a culture shift for all of us. Versus giving them a grade. They're chasing the grades.
Could I comment on that too? If I understood your question right, although redirect me if I didn't, but one of the things that we did when we went to the competency framework was we also then modified the framework for admissions. So we call them pre-competencies. And I think one of the possibilities for maybe what you're bringing up, if you move to a framework like this, is to try to level set across those domains that Jean showed. So one of the things that we're striving for is, and I had a third example, I took it out because I didn't think we'd have time, but it was an example of sort of the amount of assessment in programs and what they're focused on. And it shouldn't be a surprise that most of the assessment is around knowledge, if you looked at the volume of assessment. But if you level the importance of those domains, then something like professionalism as a domain or communication or those kinds of things, what you're saying, and you're trying to align your implicit and explicit curriculum to actually mean this, is you don't have to just be really good at the written exams and the foundational sciences. You also have to demonstrate, not just pass the professionalism course, which might be the only pass-fail and everything else is grade. That's an implicit message, by the way, by itself. So then if you raise the level of, no, now you have to demonstrate how you communicate with this patient, not just have your hands in the right place, before we say you're competent, that maybe that moves down, and then if you align your admissions criteria with those same outcomes, maybe you could get there. Now, I don't want to give the impression that we've figured all that out and it's a perfect thing. It's actually been quite challenging to try to do. But I took your question as, I think there's an opportunity there. And because these outcomes are driven from the health system, in other words, they're driven by the public and by clinicians, then you listen to what they're saying. So a good example is like the last few years, they're saying, okay, great, they know how to do this or that, or they've passed your tests or whatever, like they can't communicate, why are they here? And so then if you should be adjusting at the curricular level, you adjust your assessment and what they have to demonstrate based on that feedback loop.
Thank you so much for this information. I was wondering, you said 50% or so of your stakeholders for those reactor panels were clinicians, and then you brought in students, and you also wanted to bring in individuals, or did bring in individuals outside of PT education. I wondered if you could elaborate a little bit on who composed those stakeholders.
Great question. So there were definitely some people outside of PT, so medicine, medical educators, FSBPT, CAPT, who else was there? So we had, so the PTA Coalition, I'm trying to think who else was outside. So it was definitely students. We did have a small group of, well, we tried to get some patients, but unfortunately for the length of time that this went over, that didn't work. But I'm trying to think. I think it's, so PTA, is it coalition? I don't think it's a SIG. It's definitely a PTA group consortium. It was a PTA group, FSBPT, CAPT. We did have some representation from ABPT, RFE, the American Board of PT Specialists, ACAPT, APTA, Academy of Education, clinicians. I think that's it. Great question.
This is pretty cool. I'm going to write that down. Would you? In any case, especially with workforce issues and people entering and exiting the profession, are there any plans to implement or modify it to people re-entering the profession after a hiatus away from physical therapy?
It's a great question. If I had my golden, my wand that I could say I could do anything, I'd say absolutely. I think right now we're focused on this area, and it's going to be a complete culture shift. So we're hoping that in an area where we can control a little bit, meaning the students, and we can really embed this framework or this change in mind of wanting to learn and being proactive in your own learning, the student reaching out. We're hoping that they then become the champions as they move along. But the thought is definitely that what about continuing professional development? I'm involved in a continuing professional development program that does have this piece into it, but it takes a village to make it. So it's really having those conversations about some of the Con Ed companies, not just continuing education, but if you think about it, if somebody did take a hiatus and comes back, and they should be checked off again. So these EPAs, they do, believe it or not, have an expiration date on them, so that, let's just say, I was deemed entrustable on all 19. I worked for 6 years, and then I took a pause because I raised my 2 children, and then 2 years later I came back. I should be checked off again. The thing is, you would think, because I still have that 6 years of experience, my time to entrustment would probably be quicker, but at least that someone did that and watched me and assessed me and checked that off. The question is, are we willing to be vulnerable like that to say, as I'm a licensed PT, doesn't my license is active, doesn't it say I can do it? Yes, but we want to make sure that you're safe and efficient. So it's more about the culture. We want to make sure that as a returning person, I would be nervous You know, so like we were saying, my license says I can treat pediatric patients. You don't want me doing that. So, you know, we're hoping that this crosses everything, crosses the continuum. And inevitably, it's all about patient care. It's about providing high, safe, quality care to our patients that every single one. We have to stop because we're talking too long. But great question. Thank you all.
Thank you. Thank you.
So thank you all again, and remember the QR code. We have paper ones here, and you have links within the app to do your evaluations. Please do so. And of course, up here for more questions.